Thompson. Hey, Vance Thompson here, and really excited to be having a discussion with my comrades, Dr. John Gertz and Dr. Cullen Ryburn, about LASIK. And this is a podcast that is going to be for our doctor comrades out there, and so that we can all be our best for how we, work together on LASIK patients and learn from each other. And good morning, John.
Good morning, Vance.
Yeah. Good morning, Cullen.
Morning, Vance.
So let's dive in. And the first thing we're going to talk about is the preoperative situation, and that includes some diagnostics. But I think I would like to start out with, and this is somewhat of an obvious question, but maybe just some of your comments about, and maybe Cullen, I'll have you answer first, how much you rely on when you're working with a doctor who's taking care of someone for a while, their opinion on their situation.
Yeah, I think it's a really good question. We often share care with other providers, and those providers typically have a long-standing relationship with that patient. And so their opinion about the best option for that patient is based off of years of knowing them personally. And so it really aids us in being able to target and understand what the best option would be for that person who's coming in and maybe meeting us for the first time. And so it's invaluable to have that information.
And I agree 100%. You have a ton of experience at this. I always like to start pre-op discussions with, how critical it is knowing the opinion of that person, like Cullen said, has taken care of him for years. Any other additional comments on that?
Yeah, I think the prime example, and what I love to see, is when we get a referral and it says, Mrs. Jones loves monovision, has had it for 10 years. That helps us with the decision, and we can go in there and already have our mind made up on we know what the patient wants. And so we can support their decision and make them feel really good about it.
We're big fans of glasses and contact lenses too. It's really what is going to make the patient the happiest. And I find that the doctors that kind of present all the options, glasses, contact lenses, refractive surgery, most people are going to choose that glasses route, second most contacts, third most, what we do, refractive surgery. And I find that I love it when they come from that doctor versus the patient not really learning about those options and showing up in our office, because I value that discussion and relationship so much that I just find that patients that are hearing it all from their doctor and figuring out what's best for them is the best beginning to a refractive surgery journey. So let's say now the patient's in our office, we've received some good data about, how they've been over the years with regards to stability, how their eye health is, and we'll talk a little bit, more about that. And that in general, they have the right expectations. One of the things that I'm looking for first is, I'll call it, is the patient affecting their own refractive error through eye rubbing or pillow diving? How critical is that to you guys? John?
Yeah, it's huge. I think we have really good data now that a large number of keratoconic patients are self-induced. They are their eye rubbers. At the very least, we need to change that activity, but we also can use that to affect what we're going to do. And meaning much higher risk to do LASIK on those patients than, say, PRK, and even less with the ICL technology.
And I feel the same exact way. These patients, they don't realize they can be changing their astigmatism, changing their refractive error, and then ruining their vision. And so I tell patients who can't stop eye rubbing, they literally shouldn't do this. Most people can, but getting those allergies and dry eye things treated and breaking that habit, so critical. Cullen, so expectations and goals. We're really analyzing personalities. Like I tell patients, we can do great measurements and great treatments, but you still have a healing process, and this isn't perfect. What are you thinking about as you think about how they did with optical devices, how their personality is, how are you analyzing that in your initial discussions?
Yeah, I think it's really important to understand, what's the motivation behind them being in the office that day? And how is it that are they doing really well in their glasses or contacts, or are they unable to use those for any specific reason? Is it a motivation to be able to aid them in some part of life that's being held back right now? And then another thing that can be really important is how quickly that visual recovery needs to happen. And because we know with things like LASIK and ICL, the visual recovery can be pretty quick. And so if it needs to be something where they need this to be done and the vision to be really sharp in short order, maybe we're leaning towards one of those things where if the patient says, for example, like I'm a boxer, and so getting hit around the face is part of my job. And so we might lean towards something like PRK, where the recovery might be a bit longer, but might be a better fit for that individual person.
And especially for those low to moderate corrections, I find PRK, can be great. And also, occupational reasons, whether it's high performance athlete or military, PRK is oftentimes a great option. John, what about nighttime image quality? What are you thinking about in a LASIK consultation in someone who, maybe says it's crisp versus not?
And so I think that there's a lot of information out there about night vision after LASIK that's derived from some very old studies when we were doing very small laser ablations. And there was a significant decrease in night vision and quality vision and halo and glare. With the new lasers, we're doing very large laser ablations now with blends and really nailing that profile to give them the best night vision we can. And so I think more of that is historical, but in the short post-op period of time, it's still real. And so patients will come back and say they see a little halo and glare at night. But over the first even 3 to 6 months, it improves dramatically.
So, John, let's say in that consultation, someone comes in and you're, wanting to learn about their image quality. What are you thinking about?
Yeah, and so, this really comes into play with patients that are in their 40s, 50s, and 60s that are coming in looking at refractive surgery. Oftentimes we'll ask them about their night vision. If patients say, man, my night vision's as good as it's ever been, I think it's fine to proceed with LASIK. But some of those patients are saying, one of the reasons I'm here is my night vision's not as good. I'm having problems seeing with the lights at night. Then we really start leaning away from corneal refractive surgery and start thinking about lenticular surgery or doing a lensectomy instead.
I agree 100%. Any additional comments, Colin?
Yeah, I think, we have a lot of patients who come in that have had LASIK in the past and say, hey, I think I might be interested in a LASIK enhancement because my vision has gotten worse and like we've been discussing, increasing glare. And so for those patients, I start to introduce the discussion about these really are changes more from the cataract, and we'd be better served for going ahead and talking about a cataract surgery that could last a long time rather than a LASIK enhancement that is only going to last for a short time.
Absolutely wonderful. And so, we see a lot of patients that are coming in that day to get everything. They're having that exam and they're having that treatment. And one of the things I think about is that tear film. And so, John, how important, how much do we rely on that ocular surface being optimized before they come?
Yeah, probably the most important thing to do before surgery. If we actually break down the optics of the eye, 2/3 of the refracting power of the eye is the air tear film interface. And so, whether we're doing LASIK or doing lenticular surgery, it's still the most important optic of the eye. And it's not something that we can treat afterwards because it affects the measurements that we do beforehand. So those patients that come in and have been pre-treated just do better.
I agree 100%. Colin, any additional thoughts on ocular surface preparation before those see and do's come in?
Yeah, it's just maybe to just reemphasize that it's probably the most important thing we can educate patients about, because all of our planning is based off of the images that we get from the front surface of the eye. And without having good pictures, we can't make good plans. And so in addition to having people use artificial tears, I really push for warm compresses. And I tell people that warm washcloths just aren't enough. So I often will have people get some dry rice in a cloth sack or into a sock and heat it up in the microwave, or get a heating mask from the grocery store and use that in addition to really help the oil glands give a really nice tear quality on the surface of the eye, in addition to those artificial tears, because it's invaluable for us.
Yeah, I agree. And so you both have reviewed beautifully the significance of the air-tear interface and just how important it is for image quality. And I think patients appreciate understanding that there's over 1,600 proteins in our tears. Our tears are antibiotics. Our tears are antivirals. They're antifungal. Our tears carry oxygen. They carry nutrients. They carry healing factors. They're extremely complicated. Like I tell patients, they are the blood of the cornea. And especially where we do LASIK, there typically is not blood vessels. And so for that healing, it's so important. So there's a very profound therapeutic benefit and a very profound optical benefit. And some very important studies have shown, just like you said, John, that ocular surface, if not optimized, it throws off the measurements. And here we're getting ready to etch this correction into the cornea for the rest of their life. And we want those measurements to be pristine. But studies have also shown if we don't treat that ocular surface, the actual healing process, the accuracy is less. And so if we want great measurements, great healing, accurate results with quality vision, optimizing that tear film is so important. And so the final thing I'd like to talk about in this, really exciting pre-op diagnostic side of things, and I just thought about this, I think there's two final things I want to talk about. One is, we all know the importance of corneal topography. Cullen, I would like you to just briefly describe how epithelial mapping is complementing topography.
Yeah, so I think epithelial mapping has been a really important development in technology, because we can see on topography areas of which may look like a normal surface, but then through the epithelial mapping, the epithelium could be really thin over an area that might have looked otherwise unremarkable. And so that might be able to show us that this patient's actually at a higher risk for keratoconus than we would see with our traditional scans. So I think it's been a really big step forward, and not even for LASIK and PRK, but also for managing things like keratoconus, because we have some keratoconus patients that their topographies might look similar visit to visit, but their epithelium continues to get thinner, so that they're having this mild clinical progression that you wouldn't pick up. So I think it's been really helpful for ophthalmologists for sure.
I agree. And so, John, you've seen a ton, and I think a case like this would mean something to you. But this was a guy who saw me, -1 Dr. Myope, had LASIK 20 years ago. And it wasn't done by me, but it was a very quality LASIK. And he had regressed to a -1 in each eye, and he was a 42-year-old. And so we thought we would try just treating one eye. So he'd have the other eye to see his cell phone, some mini monovision. And I really decided to do PRK over his LASIK because it was a small correction, -1. 6 months later, he comes back, he's -1 again. So early on, he, was, doing quite well, but he's now -1 again. Between that treatment, because this was about 5 years ago, between that treatment and 6 months, we got an epithelial mapping device. So I mapped the epithelium in that eye, and it was 90 microns thick when it's, as we all know, it's supposed to be 50. We went ahead and did a lip flap and laser, and he did absolutely beautiful. So, Cullen talked about, how helpful it is therapeutically to make sure elevations aren't also accompanied by epithelial thinning, which we would be worried about in early ectasia. So it's so helpful in that. But what about enhancement decisions? How are you finding epithelial mapping helpful with enhancement decisions?
Yeah, absolutely. I believe the majority of regression with LASIK is actually caused by epithelial hyperplasia. And so, the same thing would happen with enhancements in the past with patients being hyperopic. So they come in, they're a -1, and you do their PRK and they come back and they're a +2. And the reason is because you didn't know what the epithelium was doing. And so when we look at a patient now, if we see epithelial hyperplasia or thickening of the epithelium, we'll much likely do a lift flap LASIK enhancement versus doing PRK.
Yeah, I agree, guys. Epithelial mapping has been a game changer for enhancement decisions and for, preoperative screenings. And the final question I have is for you, Colin. The amount of LASIK that is happening in this country compared to 20 years ago is lessened, but we still have a robust amount of consults. And I feel like the reason LASIK has lessened is we've learned what its sweet spot is. And we've learned where, we should consider a phakic implant or a lens replacement, a comprehensive approach to refractive surgery. And what are your thoughts, on how other technologies like implants have helped with the safety and accuracy of LASIK?
Yeah, I think the addition of all of these new technologies like phakic IOLs, ICLs, and then also some of the newer lenses such as trifocal lenses that give patients so much more range than they used to have, and more of a continual amount of range with lessening amounts of night vision complaints. And it really has opened the profile so where when patients are starting to lose some of that range in their vision as their normal lens, their natural lens is becoming less flexible, so they're losing functionality of their normal natural lens, we're able to use some of this new technology to supplement what they had lost. And so I think that has really changed the way that we've thought about who is going to be a good candidate for what specific type of technology. And I think the other thing that can't be understated is just how much the imaging technology that we're using now to screen patients provides us such good information on who is and who is not a good candidate for LASIK. And I think one of the things that the patients really expect and appreciate from us is our expertise in saying who is not a good candidate, because not everyone who walks in the door is going to be a candidate for doing something like LASIK. And one of the most difficult but most important conversations to be able to have is to say, hey, I don't think that this is a good option for you right now because it's not going to set up your long-term vision goals. And I think the best thing for you right now is to wait until we lose some of that functionality, so then we can supplement it in the future and have the most amount of options available to us.
Yeah, I agree. I agree 100%. Well, I want to thank you two. You're both so experienced on how to handle these, preoperative decisions and discussions and use modern day diagnostics to the best of our ability in this comprehensive approach that who should have, LASIK or, PRK or phakic IOL or lens replacement. And I always like to end discussions, like this to the doctors that we get the honor of working with. We love it when doctors come in for their mini fellowships in whether it's, refractive, cataract, cornea, or glaucoma, and we dive even deeper to issues like this. So thank you two for this wonderful discussion.
Thank you, Vance.
Yeah, thanks, Vance. It's been, great to be discussing this for sure.